Hi, my name is Jessica Nelson, and this is the Mental Health OT podcast. Today, I'm going to be joined by two individuals, one of which being Dr. Erin Dallman. Dr. Dallman is a licensed occupational therapist and assistant professor at Rutgers University, the state university in New Jersey. Dr. Dallman is a translational social scientist with a research emphasis on improving the lives and well-being of children with intellectual and developmental disabilities and their families. Dr. Dallman employs a multi-informant and mixed methods research approach to improve the quality of occupational therapy and services throughout the lifespan, from improving measurements in developmental disabilities to developing innovative and community-driven treatment approaches. Dr. Dallman is also the founding director of Nexus, a community-based transition skills intervention that implements neurodiversity affirming supports for autistic adults. Dr. Caroline Welch will also be joining us today. Dr. Welch is a licensed occupational therapist and academic fieldwork coordinator in the Occupational Therapy Doctorate Program at Rutgers University. Dr. Welch has over 22 years of clinical experience in pediatrics and has worked in early intervention, outpatient pediatric rehabilitation, and school-based settings. Through her time as a clinician, Dr. Welch has had the wonderful opportunity to utilize a strengths-based approach while working with children and families in their most meaningful contexts, and has strived to foster overall health and well-being across all age groups, diagnoses, and abilities. Much of Dr. Welch's clinical and academic work has focused on advocacy, access, and education endeavors to support the disability community. Currently, Dr. Welch serves as a board member for Club Dreams, which is a community-based enrichment center through the Down Syndrome Association of Central New Jersey. In this episode of today's podcast, we will be discussing the definition of neurodiversity. We will also be discussing occupational therapy's role in providing ethical and meaningful treatment for people who fall under the neurodiversity population. So welcome to the Mental Health OT podcast. Thanks, guys, for being here.
Thank you so much for having us.
Yeah, super excited. So today we're kind of talking a little bit more about neurodiversity and occupational therapy, supporting the mental health of people with neurodiversity. So that could be like autism and other diagnoses. And really, I just want you guys to kind of open up the floor with what is neurodiversity and what does that look like?
I think I can take that one, Caroline.
I was going to give you the floor.
Excellent. Neurodiversity is one of my favorite topics to talk about. And really what we're talking about when we're thinking about who is neurodiverse, who is this population, it's an umbrella term. And it just encompasses this group of people whose brains function a little bit differently than what we might call the neurotypical or maybe the neuromajority, as you'll see in the literature. So it is... the brain and its processing is a spectrum just by definition, but it also is a variety of spectrums because it includes things like sensory processing happens in our brain, happens through our spinal cord and our nervous system, but it also includes other systems like executive functioning, memory, and even more beyond that, emotions, etc. So when we think about all of those individual parameters of neurological functioning, all of those different domains, each of those is on a spectrum. And so neurodiverse people are people who fit on at some part of that spectrum beyond the sort of majority of people. So we think about the things, if we imagine a bell curve, people are sort of on those fringes of those bell curves, whose brains are just seeing the world a little bit differently. Sometimes they're sensing the world differently. Sometimes they're emoting or experiencing emotions differently from the neuromajority group of people. And sometimes it just means an overall differences in, say, executive functioning or executive processing. So as you said at the top of the show, autism is part of that umbrella, but it also includes other terms, other experiences like ADHD, I would say anxiety disorder, depressive disorders, schizophrenia, and a whole host of conditions that involve different processing.
Including even intellectual and developmental disabilities can also fall within the realm of neurodiversity as well.
Sure. Yeah. Good point.
Beautifully put. I like how you said that it's a spectrum because I think that it's really easy for people to kind of have this binary thinking of like, you either have it or you don't. And it's kind of just like this black and white. But in saying it's a spectrum, it's kind of like, well, we're all kind of on the same line and we all kind of like sense things differently. And Yeah, I think it's kind of like it's more unifying when you use that type of language in a way.
I think
You
I think
Oh, go ahead.
sorry to
Yeah.
interrupt. I think it's all about opening up conversation, right? Anytime we sort of enter into these sort of language terms, it's really hard because we don't want to also minimize the realities that people who
Hmm.
are neurodivergent have difficult lives and have challenges. So I don't want to say that we all have challenges. So we're all part of the spectrum. That's not quite what the neurodiversity paradigm would tell us. What it does say is it invites conversations to say, how is your brain processing this moment? How are you experiencing emotions today? What is your experiences with executive functioning? And it just invites us to think a little more humbly and to open the conversation with everyone to see where they fit along the spectrum, which I think is really exciting.
Yeah, and to me, just like a new way of thinking in general. Because I think a lot of times, like with the medical model, like I said, it is like that, like really binary thinking of like, this is what's wrong with you, and like we need to treat this. But instead, it's like, well, this is like what you're experiencing, and it doesn't necessarily mean something's wrong with you. It's just your reality, and like, how can we adapt things to make your experience and you be able to be more functional while experiencing that.
I love that the neurodiversity movement has brought so much attention and really helping to reduce the stigma, that goes along with this umbrella and where we all fall. I mean, every day our bodies do something different. You might wake up and you feel really great for that day. There's other days you might wake up and I need 4 cups of coffee to kind of feel alert. And, where someone else, they might need to jump. And that's what helps them kind of maintain their attention. So we all have different ways. And it's kind of bringing this awareness and recognizing that all of our bodies work differently. We all require different input from internally, externally from our environments. And it's not good or bad or right or wrong. It's just a little bit different. So, and you'll see me even today, like before, as we're talking, I was a little bit very excited and I'm having a hard time getting all of my excitement out. So I'm wiggling and I'm moving. And that doesn't necessarily, again, mean like good or bad. Someone might notice it if they're watching like the video, but it's definitely helping me to stay attentive and focused and be part of this conversation. You can't see what my legs are doing. They're fidgeting. I'm moving all around. So all of these things that can be, looked at or frowned upon maybe in the past as being different or maybe not functional or socially acceptable. I think bringing that kind of awareness that I just love where this movement is going and how much has changed from when I first came out as an occupational therapist to where we are now. It gives me hope.
Yeah, no, I completely agree. Definitely, like even in my small time practicing and like from starting school to now, I feel like I've seen like little baby steps as well. So it is really cool to like see and be a part of and like witness and help support like positive and meaningful change. Can we dive a little bit deeper and talk about what exactly is sensory processing as well as executive functioning?
Sure. I'll start off with sensory processing because I think it's the most relatable for all of us, occupational therapists, and even more broadly. The sensory processing is how we engage in the world. There is, as far as I know, literally no way for us to know where we are, who we are, what's going on in the world without our sensory systems. Our sensory system tells us what's going on, what we can see. It tells us what we can hear. It tells us where we are in space. Am I falling? Did I just go skydiving, or am I sitting at my desk? And it tells us what's going on inside. Am I feeling anxious? Am I feeling excited? Am I hungry? Do I need more coffee? All of that is happening through a sensory system. So it's our way of taking everything around us and integrating it into our bodies and into our minds and understanding what is going on. So it's our anchor. It's our anchor to reality. It's our anchor to our occupations, to our participation, to doing the things that are meaningful to us. And because it is that anchor, it becomes the way that we literally experience the world. So by definition, these populations who identify as neurodivergent their anchors are going to be different than you and I. Some people may prefer really quiet spaces. And those quiet spaces are where they're going to process and sense the world, where they're going to be able to engage in the most meaningful elements of participation. For others, it's going to be loud sounds. And they need the music. I have relatives who have music going constantly, really loud and they're talking over it and they're have like the TV blasting in the background. Overwhelming for me, but for them, that's regulating, and that's the anchor that helps them to move about and to participate in occupations that are meaningful to them. But I think for most of us, what the sensory system does is we need a variation in sensory experiences. We need a little bit of quiet, we need a little bit of movement, a little bit of loud, and that sort of variation is where we find that we can be successful in participation. So I think that the way that I like to put it is the sensory system is everything. It's everything that tells us where we are, who we are, and what's going on around us. Our executive functioning system then is the system which tells us a little bit more about the processes that are happening around us. So the sensory system brings it all in. Our executive functioning system sort of tells us what to do with that information. The executive functioning system is an umbrella term for a variety of cognitive functions and includes things like task switching, task inhibition, cognitive flexibility. So there are some components of executive functioning tied with memory. But it's this broad system that helps us to sort of make decisions and make, I guess, decisions and processes about all that sensory information that is coming both from within and outside of us.
Kind of how we respond sometimes. I was going to say it's sometimes like how we almost respond to sometimes like this sensory information kind of coming in and what we're perceiving. And then that cognitive piece comes in that can impact motor planning and maybe some of like our behavioral what we're just demonstrating and how we respond to this sensory information. So, when you go to touch a stove that's really hot, the sensory information comes up through my brain and my central nervous system. And it's like, whoa, this is dangerous. So my, cognitive processes kick in and be like, remember, this is dangerous. Pull your hand away. So, and developing that kind of learning. So it's interesting that there's this cognitive piece that also goes along with the sensory piece.
The thing I would add to that, Caroline, is sometimes I think we think that executive functioning is really about things that raise to our awareness. But both sensory processing and executive functioning often happen under our level of awareness. These processes are happening whether or not we think about them. Task inhibition it's constantly happening. There's an amazing amount of sensory experiences happening at any one moment, whether if you're right now noticing the chair you're sitting on, if you're standing, the shoes, your socks, if you're wearing them, all kinds of information, the smell of the air, the taste. But your brain is focusing hopefully on the podcast or maybe something else. And
who knows? Yeah.
Maybe it's cooking, maybe driving. But all of that is our brains are happening under the layer of awareness. And so that has important implications for mental health, important implications for the neurodivergent population, because if it's happening under your awareness, but it's still impacting your mental health or emotions, that's going to come out. It's going to come out in your participation. It's going to come out in your ability to perceive that you can engage in a certain occupation, and it's going to impact even the quality of the occupations that you do.
And the sensory processing piece, it makes sense that it ties directly in with the emotional piece and that it is kind of in the subconscious by how it travels through the brain. So there is like that direct tie between like mental health and sensory processing and executive functioning. By the way, it goes through the thalamus or the amygdala in your brain. And that's sometimes where we don't have a conscious understanding of our reaction. But if somebody is, if someone's very sensitive to loud sounds or to overly sensitive to tactile information, their brain could actually, by how it's being routed through their brain and how they're processing, it can really be perceived as this very negative, harmful, toxic experience for them. So it might result in behaviors like, even if I just meant to touch someone gently, like it could come across as very offensive and very threatening, which can then trigger this kind of response, an unexpected response that you might not like, but I just meant to touch you lightly. I didn't mean to like offend you, but maybe that person's withdrawing. Maybe they, act out in some kind of way. Maybe they push you away. And that's just their natural response to kind of understanding and processing this information.
Yeah, I think that, both of you put that beautifully. And I never really connected sensory processing and executive functioning in that way, but you were like really able to like seamlessly explain and connect those two things. So I could tell you're a good professor. Your students are lucky. Both of you, for sure.
Aaron is fantastic.
They would tell you differently, but
That's not true.
I do think, Jessica, that is a really important connection. Your sensory experiences and your emotions are very much tied, and that your ability to regulate your participation in occupation is going to be so much tied to your sensory experiences in ways that you just don't know. There's a reason why hangry is a concept that we can all resonate with. It's just, you may not be aware of it, but I'm going to tell you, your occupational participation is going to change if you're hangry. But it's beyond that. Like, all of our emotions are so intimately tied with our sensory experiences. And that's why there's a link between sensory processing patterns and other mental health disorders like depression, anxiety disorders. There's a link here, and we know this empirically. And that's because sensory processing is, of course, how we're going to, it's going to change our emotions, and it's going to change how we are experiencing all that we're doing.
Yeah, I can definitely relate a little bit too. So like, I'm the type of person, I am very, very sensitive to like sound. And like, if I'm like trying to read something, or if I'm trying to like do like anything, it has to be quiet. If someone's talking to me, if there's music on, like anything, I can't like process. I'm just like reading the same like sentence again and again and again and again. And I'm like, what's happening? And so like, a lot of times with my boyfriend, like I'll try to be doing something, but he wants to like hang out, but he's noisy. And so I'm like, no, like you need to go to the other room. And like, I get angry. And so like, yeah, like that emotional effect of like, I can't do what I'm trying to do because of this input that's like affecting me. And now I'm upset about it. And now I'm angry about it and frustrated. And so, definitely.
And we have to think about that for our clients as well. So often when I see new grads and students working clinically, they feel as if they must fill every split second with sound. And they're talking to clients, particularly the autistic clients that I work with, and they just want to ask a question and they don't get a response. They want to ask again or ask a different way. And it's overwhelming for me. And I think what it's got to be like for this client. Sometimes there's some beauty that happens in silence. And for some of our clients, that's really what they need. Then they're going to process, and then that's going to give them opportunity to really flourish through occupational participation and flourish, and their emotions they'll be in a better regulated state.
I think you both draw on something like very important, both with Jessica. I think that's like perfect example, and just how our sensory, we each have our own unique sensory needs. We each have different ways of responding to this sensory information. And then Aaron bringing back, like, we have to remember this when we're thinking about the people that we serve, knowing how sensitive you are, Jessica, like with sounds. Imagine a kiddo. I always come back to, the children and the families that I serve, and thinking about this child now in a classroom full of 30 students. It's loud. There's a lot going on. And then yet we expect them to learn and be able to sit there and do their work and not act out and not have any other kind of, negative response, even though their body is in complete overload. And I think these things, like, we have to put ourselves, in their perspective and what they're going through, and look not maybe at like the resulting behavior that they're throwing their things on the floor, but why, what is happening to make this kind of, to make them act out in this way. And a lot of times, like for just kids across the board, they don't have the same level. We're all adults here. We have this cognitive process where I'm much more aware of my body at 45, maybe more than I'd like to be, than someone who's 7 in the classroom and maybe neurodiverse. And I have the words to tell you, like, this doesn't feel good. I feel overwhelmed. I need a break. But they don't always have that kind of language to advocate for themselves. So I think, what Aaron said, and like really remembering who we are serving and, putting ourselves in those positions, I think is only going to help all populations, all children, all humans that we serve, and also help us to be more relevant and meaningful, like professionals in supporting and advocating for them through this process.
Yeah. I like that you bring up the point kind of like more school-based and like kids who need extra input or maybe like less input and stuff like that, because I feel like it's so easy, and I've seen it so many times, whether it be like family members or something, there's this pretty hyper and active kid who's like doing a bunch of things and like, you know, and they're like, oh my gosh, he's so bad. He's bad. He's bad. He's bad. And it's like, well, is he bad or is it something else? And like, but I don't blame the parents either. Like, I mean, they don't know. And like, how would you know if you're not educated on it? And so really, I think just the education piece alone of like, not bad, but just has different needs, and just providing that. Because if you're a kid and you're having needs that aren't being met, and then you're just constantly told, you're bad, you're bad, you're bad, and you're like, well, why can everyone else around me like control themselves? And why can't I if like, you know what I mean? But like, I think it's more validating if you can kind of explain maybe in a way to a kid that maybe you have different needs and stuff like that. Obviously not go into like the deep depths of sensory processing and stuff, but maybe in a way that they can understand better. Yeah, I just think that it's more validating for them and then also the parents, because I also feel like for the parents, there might be a little bit of, I don't know, maybe like guilt, like maybe, is it me? Am I doing something wrong? Or like shame or like just not understanding.
I think you tie like right into like the stigma that goes along with it, you know, like, is there really a child that's innately bad? I don't think I've met one that's innately bad. There might be things that people view as like a bad response or a negative response, but really what is ultimately going on to elicit that kind of response for that child? Just like this, like, you know, you have people who are like, well, he's just really lazy. Is there really like a young child that's like lazy, or is their body just processing things like a little bit differently? And no wonder like the stigma, like, and being told that you're bad or that, you know, like your behavior is bad. I mean, no, like that's going to impact your mental health, like along the way, both, I mean, and across into adulthood. And maybe that does impact the decisions that you make later on. But like, it's something, I don't know, it's so hard. It just dives right back into like the negative stigma of, you know, individuals that process things and that feel things differently.
Yeah, I think that to me speaks to behavior change theory and like how do we support clients to be successful? And we can punish them, we can make them fearful of outcomes, which is sort of this idea that you're bad, you're lazy, we're punishing them for that sort of thing. But what we know is those behaviors will not be maintained. They will immediately get extinguished as soon as you withdraw that punishment, that reward, whatever that system is. The reason people become motivated to do something, the reason why people stop going to the gym or continue doing it, is because it becomes an element that's part of your identity. When you support someone in understanding their identity and understanding how a behavior or an experience is part of who they are and why they are who they are, then it becomes something they can better do and apply. I'm not doing a sensory routine because I'm a bad kid and I need this. I'm doing this because I'm a strong kid and this is how I demonstrate my strengths. This is what I do to be in the right place. Just like I need a cup of coffee in the morning to be in the right place. It's the same sort of model. But that's what strengths are about. And that's sort of what the core of this neurodiversity affirming movement is. Let's recognize that we have pathologized and problematized a lot of conditions for a long time for no reason. And we can be critical of that. We can reflect on that. And we have made mistakes professionally. I have made mistakes professionally, and that's okay. But we're science. We are a science-based profession, which means that we can move forward and identifying what is the next step. And I think that's what we're highlighting here. Let's find these kids' strengths. Let's help them to see their own strengths. And then that's going to affirm their processing patterns and also affirm this, help them to be more successful in occupations in the way that they want to participate in them.
That makes me just want to cheer.
I know. And scene, cut.
Yes, yay,
yes. So all good things. I also kind of just wanted to talk about really quick, changing gears a little bit, because it is very clear that both of you are so passionate about this topic and have so much interest in it. What sparked your interest in it?
Well, I think for me, I probably teeter within like the neurodiverse. Growing up, all I heard was very negative stories about myself. I love my mother dearly, but about my sensory processing system. I was a screamer. I would have these terrible, awful like tantrums that would last hours. My hair had to be a certain way. My clothes had to feel a certain way. I was an absolute nightmare to feed. I wouldn't eat. And I have been lucky enough to also have a daughter that is built just like me, where clothes have been an issue and all of these sensory processing things all along the way. So I think knowing that, as I got older and became a little bit more aware of myself and what feels good, I didn't really know, in high school or anything like that. I didn't know about sensory processing at the time. I mean, we're talking early 90s. So things were very, very different. My mom by trade is a learning consultant. So I spent a lot of time going into work with her and like going in and out of like the different classrooms where like neurodiversity definitely existed, a bunch of different kinds of diagnoses and kiddos and abilities. And I think that that's really where I first like fell in love, and what kind of moved me and pushed me into this direction of even occupational therapy. I think because it made sense to me. It made sense to my body. It made sense to my mind. And I'm like, oh my gosh, like this, like it was very relevant and meaningful to me. So thankfully, like my mom really pushed me in this direction of and pursuing like my dreams and my interests in this area. But I think what ultimately has made me a better clinician is really like being a parent to a child that also has really struggled with anxiety from probably birth on. There's been medical complications when she was small, which led into very like pretty extreme sensory defensiveness and things that made life definitely more challenging, really up until like through her middle school years. It's really just been recent where things kind of have like come together. So watching that and now being in that parent position like has really, I think, helped me to better understand and to also be, not understanding is probably the right word, but like maybe advocating a little bit more, and being able to accept and try to meet the child like where they're at and how can we use that strengths-based approach. Because we try when my little one wasn't eating, you try everything. At this point I was working in early intervention. I knew I had all the tips and the tricks that I would share with families all the time. None of them worked on my daughter. None, not a single one. Like people, she wouldn't eat. People would say she'd eat when she's hungry, and I'm like, no, nope, she's not going to eat. Like she doesn't feel hungry ever. Like there, all of these pieces. So I definitely think, like Aaron had said, like I've made mistakes in the past as a clinician, and not having a full understanding, but through like experience and being open and receptive of change and kind of acknowledging like where I did take a wrong turn in the past, and really then rerouting, meeting my own daughter, like where she's at, like it really did help me to be a better clinician and to kind of understand this process. That was a lengthy answer. I apologize.
No, yeah. I think I love answering or asking these questions because it's always something so personal to them. And it's something that like a lot of times where I work, people will be like, well, people get into mental health either to figure themselves out or figure someone in their family out. So it's always fun to hear the stories and like the personal connection to like the work that they do. So
yeah, very personal start.
I want to go back on one thing you said, Caroline. You said you've made mistakes. You haven't made mistakes, but instead maybe like small ones. But what I want us to think about is that we as a profession are responding to new science, and the science has changed, it's improved, and that's all that we're doing. This isn't about mistakes. It's not about right, wrong. There's no judgment in it. It's simply about let's follow the science, let's follow the new evidence, and that's what we need to do. But the question, how did I get into this? I think any of my students can probably tell you this story, which is that I got into this world kind of kicking and screaming. I started my PhD and I was set that I wasn't going to be a part of the autism research community. I felt there was too many researchers out there and it just didn't. I was worried about that and worried about being in a saturated field. And I didn't feel like I had something to contribute. But I was working with my mentor, Dr. Brian Boyd, and we were having lots of conversations about mental health and autism. And it spawned this interest in me that has continued to just grow in so many different ways. When I learned how many autistic individuals have depression, anxiety, suicidality, have attempted or reflected on committing suicide, and it just got me wondering more about why this is happening. And the more that I talked to autistic people, the more that I was into this community and hearing from them, there's one thing that stood out, and it was that they felt like the world wasn't built for them. It wasn't autism, it wasn't a diagnosis, it was the world isn't built for us. And in fact, it keeps telling us to change, keep asking for us to change. And I thought, I mean, I can't imagine living in a world where you don't feel like you belong. That is the fundamental principle, I think, across mental health. We all deserve the right to feel like we belong. And as I started to do the research, I started to talk to the community, I started to reflect on what this meant, and broadly in the developmental disabilities population, it has started to sort of grow into really everything that I do. I think about it a lot when I teach. I consider my teaching pedagogy approach to be neurodiversity affirming, because students also have the same sort of challenges. Students are also part of this spectrum, have different ways of experiencing the world, different ways of processing things. And when they don't feel like they belong, they can't learn, they feel like they're stressed, and it's going to decrease the quality of their engagement and participation in the classroom. So fundamentally, I think what brought me here was this desire to make the world a better place for the autism community. And as I sat myself into that space and started to be a part of these conversations more broadly, I realized that this conversation is about a much bigger population and about a more fundamental issue, which is let's make this world a little bit more inclusive, and I think that we can do that kind of work.
Yeah. Wow. Yeah, I love all of that. I love both of y'all's stories, and I think that I think it's so important how you mentioned, Erin, that you like went to the source. So like you had discussions with these individuals to figure it out, because I think so often we just, in general, the medical community, healthcare, we just have these assumptions that we go off of. And I think that it's really, really easy. It's almost like, and I see this where I work, the more educated you are, the more disconnected you are almost. And so reminding ourselves that, yeah, we have all of this education and we know all of these theories and like the research and blah, 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 blah. But it doesn't really matter if we're disconnected from our client and the person we're serving. So always like starting at the root and then applying our knowledge instead of starting with our knowledge and then trying to make it fit treating this individual or providing services.
First off, I feel personally attacked that you're because as a person who went all the way through the PhD, more education means more disconnected. No, it's fine.
Sometimes, not all the time.
It's true. But I think the other thing that I would add or invite people to reflect on in the conversation is that it doesn't mean that we can just go to people and use our medical language to say, let's solve all of your life problems. Mm-hmm. That I think sometimes it can be easy to feel that way. Oh, let me ask you what you want to do. Oh, you didn't answer. Well, that means you can't communicate. But there's differences in language and processing here. Mm-hmm. And people process the world a little bit differently. And so because of that, we need to shift our language or think about new ways of understanding that lived experience. If we can find those ways, then and situate that authority of information back on these community members, then we're going to get we're going to get rich information and sort of in-depth experiences. So I think that that's kind of the new frontier for occupational therapists and speech language pathologists and this rehabilitation world, is to think about how can we empower these individuals to detail their experiences, and what is the work that I need to do in order to understand the messages that they are communicating.
Yeah, 100%. And no attacking was trying to be made. But yes, I completely agree. And you use your PhD for good, not evil. So
I try to.
Yes.
You got back to your roots as an OT and really focusing on like what matters and using that like holistic and humanistic approach. It's what makes us different as a profession.
Mm-hmm. 100%. So I know that we talked about this we touched on it. But let's talk about just a little bit more in detail, individuals with autism. What does this look like? And I know that, right, it's a spectrum, so it can look like a lot of different things. But let's talk about that, autism in general, what it looks like, and how maybe people with this diagnosis experience the world and maybe some barriers that they experience.
That's a big question.
It is. I think, good luck.
Thank you. I think we should start off with a conversation about language, which is, so we're talking about the autism community. There's kind of two schools of thought. One is to talk identity first, that is autistic individuals, and the other is person first language. And already in this podcast, I know I've used identity first, talked about us autistic individuals, and you, Jessica, just use person first. And I want to go out to say that both are considered to be okay in the autism community. Some autistic self-advocates have said they like the identity first language, they align with that. Others have shared they like person first language. So I think that there's some recent guidance that we should use it flexibly. But I just want to say to any listener out there that the goal of all of this language decision making is to be respectful. And I always tell when I'm giving talks and to bigger audiences, I invite the audience to just kind of Command F or Control F in their mind. If they prefer one style of language and I'm using another, to just replace it, because that's really the goal here, is to be respectful. But the question was, what is autism? And so the way that I like to think about autism is that it is a neurodevelopmental disorder characterized by differences in sensory processing, that is differences from the neuromajority, differences in social communication, that is they communicate differently about their social and experiences, and focused interest, often having focused or specific interests. Autistic individuals, because they have these differences, they often look different from the neuromajority population, or they're certainly experiencing the world differently. Sometimes that means they're more sensitive to sensory information or less sensitive to sensory information. They may not hear their name when it's called, or may not process it, it may not rise to their level of awareness. They often have a lot of focused interests. So some autistic individuals are very interested in a variety of topics. Sometimes we think that autistic individuals are all interested in trucks and cars and that kind of thing, based on sort of an old model understanding about where autistic interests are. But the new science is saying is that most autistic individuals have really focused interests or passions at one time. And those passions may be varied and they may shift throughout their lifespan. They might be I knew a guy who was very interested in fire extinguishers, could tell you everything. He had a whole collection of them. He could tell you everything about every one when it was created, and all kinds of exciting things. And then later in life, his interest shifted to World War II. And then now I'm not sure what his interest is. But that's some of the better science that we're seeing, is that it's really just about a very focused interest. And then what was the last? Social communication, which is the autistic individuals communicate and interact socially differently than the neuromajority. So some autistic individuals have reported that they find eye contact to be painful, which means that any interventions that ask them to make eye contact are extremely uncomfortable for them. Other individuals communicate bluntly and may use very direct language, which, as somebody who really appreciates blunt language, I've had many community members tell me that I don't have good fashion, or that they do or don't like my bow ties that I often wear. Not today.
I love the bow ties.
Thank you. And but generally, the way that they're processing social information is just going to be a little bit different from that neurotypical population. It is, as we said, a spectrum, and so some individuals are certainly going to have a lot more variation in their sensory processing compared to the neuromajority. They're going to be very, very sensitive, and it's going to become really bothersome when there's altered sensory information happening in a room. Others are, of course, closer to the neuromajority of the population. But the other thing that I like to, when I talk about autism or think about autism, is to remember that, like most conditions, one's experiences and skills and processing patterns change throughout the lifespan. And so just because you're communicating this way one day doesn't mean that's the way you're going to communicate or experience the world for the rest of your life. And that there's going to be, the experiences will change. Anything I missed, Caroline? There was a big question there, and I'm sure I missed some of it.
Fill in the gaps.
No.
Go ahead.
Yes, I think that you really hit the nail on the head, as, speaking as generally as you can, because it is such a big question. An individual with autism or an autistic individual is not the same as the next autistic individual. Just like I'm very different than Jessica, and Jessica is different from Aaron. Just because you fall within the neurodiverse umbrella doesn't mean that everybody's going to be the same. We're all going to be different, which is why it is great that it is like this really big overarching kind of guide to accommodate for all of our differences. I think, the kiddos that I've worked with that have been on this spectrum, I feel like they've taught more to me, and I've learned more from them, I think, than I've ever taught them. I think there is something like their brilliance, even when they're speaking to me very directly or telling me I smell like a cookie, like their senses are heightened. Like they have really inspired me and have taught me so much, both about myself professionally and personally. And I'm hoping with the way of like this movement and just how our world is becoming more accepting and knowledgeable, and understanding, that they also have the opportunity to learn from individuals that are neurodiverse, and get to see like the joy and like just how wonderful and how much more fulfilled your life can be when you're not just surrounded by people just like yourself.
Mm-hmm.
And that there's so much to learn from others out there that maybe don't see the world through the same eyes as you, or don't feel the world through the same senses.
Yeah, I think it's really powerful to, especially as like a practitioner or clinician, to be able to like enter into a setting and maintain like that humility and be like, well, what can I learn from this situation, instead of always feeling like I have to be the expert and I have to like fix everything. Like, what can I take from this and what can I learn? So
Right.
yeah.
It's there. I feel I have learned so much over the years and have just been blown away with like the abilities and the interests of like some of the individuals that I've worked with. Just, I mean, things that at 45, I can't do. I cannot do this mental math calculations in my head that some of these, the kiddos that I've worked with. I had one of my favorite kiddos of all time was able to, if you shared your birth date,
Mm-hmm.
they could, within seconds, mentally manipulate a calendar in their head and can tell you exactly what day of the week you were born. And I mean, and I'm in my 40s. This kiddo was not alive at this time and I will never have that skill or that ability.
Mm-hmm.
Just, I won't be able to do it. I can't tell you all the times when Magic Kingdom opens and closes and when they were off and every Disney character's birthday. Like, I will never be able to do those kinds of things. But I think one of the things that I have learned, I think, from these kiddos, working in the school setting, and I understand like within the school realm and the medical realm, like we have these very strict boundaries kind of where we have to meet. We have core curricular standards, every state has different standards. And, within the medical model, we're bound by insurance and things like that. So there are these constraints. But what if like, the same kiddo that was able to manipulate like the calendar in his mind was having trouble in the classroom with like very basic math? So, but what if we took their interests, and even if it's around a calendar or around Disney or like and then we're able to individualize like that curriculum so that you're still working on like some of the skills that, the state is mandating and things like that. But we made it look a little bit different. So it was meaningful and interesting to the kiddo. Then I bet you would really see that it's not that they were having trouble with math in the classroom. It wasn't relevant. It wasn't meaningful. And it didn't like, if something doesn't mean anything to you, why are you going to want to do it?
Right.
I don't want to do things that don't mean anything to me.
Mm-hmm. Mm-hmm.
So like, again, that's something that I've learned. And it's like, it's not that the kiddo can't. It's like, what are we doing wrong? Or what is like, that social development, like, or the constructs of the environment, like, what are we doing that's limiting the child rather than encouraging and enhancing their abilities, because by golly, that student can blow me out of the water in their abilities and like their ability to manipulate math in their brain. I still count on my fingers. So,
me
so
too.
rather
Me
than,
too.
yes. So, I mean, there's so much to learn, and I'm sure I just got off track there. I could talk about these kiddos for on and on and on with their brilliance and the gifts that they brought me.
But I think what you're talking about, Caroline, is this idea like, let's use child-led interests, and that these interests might be varied. There's so much science behind that concept. I mean, it's basically an adult learning principle that we should engage individuals' interests in the learning process. It's what we do every day in our occupational therapy program. And we're trying to make sure that the material resonates with each and every student, regardless of their interest level in the particular topic area. That's why this is that's a very important concept in pediatrics as well, and then broadly in the mental health population. Again, it's about changing that epistemic authority to say, you have a lived experience, you have your own interests, and I'm going to treat you like an adult and give you the same sort of affordances that I might give the neuromajority population, and give you a chance to be interested, to be engaged in this topic. And then you're going to learn a skill. And I think that's really exciting. That's a really exciting approach, and a change in thinking about how we do occupational therapy and what best practice looks like.
Yeah. And I think that is what we're talking about. That's what makes like a good teacher, and that's what makes a good therapist, is not like looking specifically at the issue or like the problem at hand, but like being able to critically think about it and take a step back and like seeing like the whole mountain, not just like the barrier right in front of us, so that we can, come up with different and effective interventions, or meet, the people we're teaching, and present education in a way that works for them. Because like you said, like these people have incredible strengths and incredible capabilities that, I mean, are almost unfathomable, right? And I think that's what makes OT so great too, is that we are a strength-based profession. And so like that really goes hand in hand with helping people belong. And so if we are building bridges based on their strengths, that is belonging, rather than looking at all of the kind of barriers that they're experiencing and trying to change them to fit, right? That's not.
Right.
So
that's exactly right. We don't need to change the person to fit our mold of where they think that they should be, or what's the confines of society, but, and that I think has been in the past of kind of like what everyone is trying, especially like in the medical model, like, and even in the beginning of my early career, like OT was kind of like, well, they're flapping, you need to fix this. Like, so really kind of shifting. I'm so excited and so happy that we're moving in this direction and away from that, like fixing, and there's something wrong with them and we have to address it and you're here to fix it. Like, well, no, like, well, what can we do to foster like this sense of belonging and using these strengths? So I'm so happy that we are moving in this direction. And I really hope that, like through like your podcast and Aaron putting out so much research, like getting the word out, that the world also continues to shift in this direction, not just occupational therapy, but the world in and of itself.
Yeah, definitely.
I want to follow up with something you said, Jessica, and put the question on you. What does it mean that we are a strengths-based profession? Can you define that for us?
Yeah. So for me, and a lot of times in my job, it is so easy for everyone to, because like a lot of people, they are like acutely ill with a mental illness. And then on top of that, a lot of them have like forensic backgrounds. So it is so easy for everyone to be like, oh, this is wrong with them. This is wrong with them. This is wrong with them. But like when I sit down and talk with them, I work really hard to be like, well, even if they can't tell me like their strengths, I sit and I think, well, you're here and you show up to group every day. And so like maybe you don't participate a lot in group, but like you're here every day. So like strengths you have, you're punctual, you show up probably when you don't want to. So like to me, that indicates a little bit of like resilience. And I mean, with the individual I'm thinking of right now, even they were like, oh, like this medication just makes me like pretty tired and like not wanting to do anything. But again, they still get up, they still show up, and they still are able to like be present. They're respectful. So like regardless of like their past and regardless of maybe their lack of engagement, they're still doing things that clearly show that they have like certain skills. And so taking that and what I learned from that and one presenting it to them, it's like, well, this is what I see. And I think this is what like the strengths I see. I could tell by saying that they're like, huh, like, yeah, actually. And this individual too, specifically, he, before entering into or getting admitted to the hospital, was homeless. And so whenever I was doing the screen, I was asking, well, while you're homeless, and I kind of like preface with like, this might be like an unfair assumption, but did you ever have any issues? I could imagine it would be difficult maybe finding like places to shower or like places to get food. And he's like, no, like honestly, when I was homeless, I was able to like take care of all of those needs. And so like at the end, when we were talking about his strengths, I was like, it sounds like you're pretty resourceful. And like that was just something he never even thought of. And he was like, yeah, like actually I am. And so, yeah, just taking those things that whether you observe it or whether they're able to identify it, and building a treatment plan with their goal in mind that highlights and builds upon those strengths that they already have. So like, that's what that means to me.
Yeah, I think that's beautiful. And I think that, it's not just about strengths-based therapy being a mirror and reflecting to the client their own strengths, but giving them opportunity, creating a context for them to continue to grow into those strengths is just, I think, a beautiful description of what OT should be. And I just want to give you kudos and praise, because you didn't say we're using strengths to address weaknesses or anything like that, which is very medical model focused. You're just, let's build strengths. If we build strengths, that in itself is a meaningful goal and an important area for occupational participation. So I like that a lot. And I think that's very much in line with this neurodiversity affirming approach and this way of thinking.
Yeah. Whew. Glad I passed the test. Might have had to cut this section out if I didn't answer that correctly. But yes, okay. So I kind of want to switch gears a little bit and talk about, which we've touched on, but just to make it a little bit easier to understand, historically, what has treatment looked like for neurodiverse populations? And like, how has this historical treatment impacted the mental health of these individuals?
Do you want to go, Erin? You want me to go? I mean, from my perspective, I find it to be extremely invasive what we have done in the past. Even thinking from my early on, when I first graduated from college as an OT, I'm shiny and bright. I'm so excited. One of the first places where I worked at the time, I mean, sensory processing, of course, was big, but it wasn't as much of like sensory processing helping the child to get an understanding of their own body and their own needs. It was more like, what can I do to you to fix this? So like, I'm sure you've heard like brushing protocols and, using vibration and doing and there's so many different kinds of things out there. And I won't get on a soapbox about those things, or, I'm not conflicting like with evidence or anything like that. But so much in the past has been like what we're doing to someone, even with applied behavior analysis, like what we're doing, like we expect this out of you, and brushing, like we're not asking the individual for consent. We're just kind of like, okay, well, here I come with my brush and I decided you are tactily defensive and this is what we're going to do, whether you like it or not. It could feel very invasive and very offending, but this is what we're going to do. So I'm happy, really, really happy that things are really kind of shifting. And where we are kind of coming back to the client and what feels right and helping them to advocate for themselves. And I'm not saying that never to use a brush again or things like that, but what if the child likes to use the brush on themselves, or what if they hate it, but kind of coming back and using these less invasive more consensual like approaches where they're able to guide like what feels right, what works for them. Because we were kind of just deciding all of these things, like, with ABA, like I want you to reach this, and this, and I'm going to place these demands on you, and you are expected to do them. But where's like the meaning or the function or anything like that behind it? So I do think that like our practices in the past have been much more invasive. And I'm just very happy that we are moving away from those. And I'm sure Aaron can speak more to that. But just it's nice in these 22 years that I've been out that there has been this kind of paradigm shift. Because even at the time as a new practitioner, there are things and you're just like, like I don't really know how I feel about this, but this is what everybody's doing. But that doesn't mean that it's right.
Yeah. Quick question. So can you go into a little bit more detail and explain what brushing is and tactile defensiveness is?
Oh, sure. I can try to jump on that. So deep pressure brushing, there's like a few different protocols. There's Wilbarger protocol. There was, I know like Janetta Burpee had like her own kind of protocol for brushing. And the idea of it is that you're using this, basically it's like a medical scrub brush to decrease the sensitivity or like the defensiveness of someone like perceiving this tactile input. So tactile defensiveness is really, it's where, as the person is perceiving like their surroundings, whether it's light touch or they're bumping into things or clothing on their skin, their brain is processing that like as painful, noxious stimuli, putting them completely in overload. So then the idea of brushing was kind of almost to come in with this overload, and we're just going to desensitize you by giving you all of this extra, tactile input. And there's anecdotal like stories where families like really saw like the benefits of this. But again, like no one's asking the child, like, does this feel okay? Or do you feel safe in this moment? Like, I'm just coming at you and doing these things and manipulating your body and, doing like, for someone that's tactily defensive, that's really overwhelming and like, and disarming, like, and it's your parent that you love and that is supposed to be there to kind of like support you. And then this therapist is saying that they have to do all of these things to you every 2 hours. Every single day of the week, whether you're in school or at home, there's so many factors that go into that. So I don't know if that was a great explanation of tactile defensiveness, but really it's like how the brain is kind of responding and perceiving this information. And usually it goes along with light touch. And it's perceiving these light touch stimuli as painful. And it really does. I think there has been studies where like if they're doing a brain scan, like the same centers that would light up for pain, like if I touch that hot stove, would be the same centers that are lighting up when you get touched lightly or you have like this, texture on your skin or things like that. So the brain really is processing it as painful. So then when you think of it like that, and then you're coming at somebody with these sensory tools and we're coming at them like, that's scary. I wouldn't like that.
Yeah.
Go ahead, Aaron. I'm sure I'm sure you're more eloquent explanation
of all of the things he wants to say.
No, I was reflecting on that example and this. I admittedly have not done a literature review on brushing protocols in a while, so I can't speak to any new research. But I do know. I mean, I do know that you're right that those when you're hypersensitive to sensory stimuli, there's overlapping activation of pain brain regions, and I'm just reflecting on myself and the thought of if I was. I mean, you could desensitize me to touching the hot stove by making me touch a hot stove every couple hours, but I don't think I would enjoy that very much. So I just wonder how quickly that desensitization process happens and what the pain thresholds are and the experiences of that. But I don't know that literature. But do you know? Have you read that? No.
No, okay. But I hope we don't go in that direction.
But I also I want to go back to your earlier question, which is sort of autism history and like the treatment in autism. And I think that a great place to start is in the 1940s when we first started to get this diagnosis of autism with Leo Kanner's early descriptions of disruptions of affective contact. And in Kanner's descriptions, what Kanner's doing is essentially describing these case studies of these individuals who were kind of basically in his language, kind of odd or weird. And that kind of idea has persisted in a lot of the way that we have conceptualized autism for the past 60, 80 or so years. Because even in our core diagnostic measures, like the autism diagnostic observation schedule, one of the things that we're thinking about as the clinician scoring the measure is how this person makes us feel. And do they make us feel awkward? Is the eye contact uncomfortable for us as a clinician? Which of course is very, I'm going to maybe say imperialist. It has a very narrow majority feel to it. And there still is not a great way of understanding the diagnosis of autism from that lived experience. Like, we don't have a great sensitive measure for that. And I think that the reason is because that we still have a very narrow understanding of autism. And we have a very narrow view about what the spectrum is and what it means. But for, I would say, the vast majority of treatment in autism has focused on reducing that weirdness, as people might refer to it, but reducing those variations in social participation, sensory responsiveness, social communication. If we can get those to fit into that normal spectrum, then suddenly you're theoretically not part of the neuro minority. What we now know is that that really wasn't true. And in fact, what we were really teaching was something called masking, and just teaching people how to be really good actors, despite how painful it might or uncomfortable it might have been. But I think now we're shifting away from that. And I think that one of the reasons we're shifting away from that is because of the rise of social media. There's one good thing maybe that came out of social media and the internet. And it's the fact that the autistic community is given a voice, and they can self-advocate, and they can build community. They can connect with other autistic community members to say, this is my experience. This is really who I am. Everyone's been telling me that I'm wrong or this isn't okay. But you know what? Now I see that it is, because I'm connecting to others. And I think there's something, again, so powerful about having community, because you can see yourself in other people, and those other people can help you see more about who you are and how you are. And then suddenly your ability to self-advocate continues to grow. So I think that we're shifting now into more of this neurodiversity affirming model because of these autistic self-advocates. And which is why a lot of my work is so reliant on their expertise, because it's really, they're the giants that I'm standing on. Their voices are what propel me to ask the questions that I'm asking.
Yeah. And I think too, going back to kind of what both of y'all said about like the evidence of brushing, for example, but I'm sure there's like a lot of other evidence with kind of old or outdated or past treatments with neurodiversity where the evidence indicates that it works, but then it's kind of the idea that it's like, well, just because we can do something, should we? And just because it says it works in theory, like what exactly is working and what exactly at the end of all of this is our goal? So kind of like reshaping, just because we can doesn't mean we should. And then like, what exactly are we trying to achieve here?
Yeah, and what are the long-term outcomes of that, right? Like, I may get you to have less sensory responsiveness in a very specific context, but if that doesn't map onto your participation in meaningful occupation, it's not really all that meaningful. And also, if you're experiencing it as painful, then that's probably not such a great goal anyways. I like that perspective a lot.
Right.
Kind of brings me back to,
go ahead, sorry.
thinking about the word like tolerate. I think so often, you see goals in school-based or even outpatient, like that this individual is going to tolerate this, this, and this. And I'm like, why should we have to really tolerate anything? Like if something doesn't feel good, like why are we being forced to tolerate these kinds of things? Like, and I know that there's things in life, I guess, in everyday life that we actually have to tolerate, when you're thinking about quality of life and someone's like own mental health and well-being, like, why are we forcing them to tolerate something? Like, how is that going to benefit anybody?
Yeah, definitely. And like, who are we to decide what they need to tolerate? You know what I mean? So
you will tolerate this glue on your fingers.
Yeah, right. I don't know why, but
right. You will.
And I kind of wanted to talk a little bit about, because I think we've mentioned it, but we haven't defined it specifically. We've talked about like behavioral therapy as well as ABA. So if one of y'all want to tackle that and kind of give a definition and maybe an example of what that looks like.
I think
I'm
you
going to
opened
give
up
you
the
the floor.
conversation. Oh, I was opening it up for you, Caroline.
Oh, I was going to open it up for you. I feel like I've been doing all the talking first. You take the floor.
So, applied behavioral analysis is a field that arises out of psychology. And the principles of applied behavioral analysis broadly are that we want to encourage specific behaviors, we want to extinguish other behaviors. I think that it's difficult to talk about ABA without talking about the perspective of autistic community members who have shared that ABA can and oftentimes does feel abusive to them because it is a therapist or a technician's goals being imparted on them, and they're being exposed to experiences that they don't find to be enjoyable, that aren't inherently motivating for them to address somebody else's goals, somebody else's experiences. ABA uses a variety of techniques in order to encourage or discourage certain behaviors. Sometimes you might see people using food to discourage or to encourage certain behaviors. There is also evidence drawn from the field where they have used other more problematic behavior tools like electrical shock. Electrical shock is still used in the United States today to discourage certain behaviors amongst autistic individuals and other members of the disabilities community. And from the voices that I've heard, the vast majority have said, all of them have said that electrical shock and other forms of punishment are unethical and unacceptable, and that it is a moral issue that it is still happening to this day for this population. What did I miss, Caroline?
No, I think that was a great explanation. And even talking about the shock, my first job out of college, there was a student that actually had a CIBUS, I think that's what it was called, machine implanted, where she would get receive an electrical shock every time that she engaged in some form of self-injurious behavior. So I'm like, okay, we're replacing the self-injurious behavior with like another like painful stimulus. Like this doesn't really seem, I mean, that's not my area of expertise, but this doesn't seem right. Like,
make
and
it make
again,
sense a little bit.
yeah.
Yeah.
Like, and I'm just like, this seems like a very extreme form of like punishment to be delivering like at this day and age to a child that doesn't even have a voice right now. Like I think again, like some of our older techniques were invasive and harmful.
And I think what's important to acknowledge when we think about other professions is the unique lens of occupational therapists and why we have to make sure that we retain our values with this population. And that I think that, what do I want to say here? That it's really important that we think about these sensory processing experiences, which the field of ABA is not equipped to address. And they do not have the information that we have about a kid's unique sensory processing patterns and how these unique processing patterns are impacting their engagement. And so if we just use positive or negative reinforcement to encourage certain behaviors, we know that we're missing a core element of our lens, and that is going to have long-term consequences on the sustainability and functionality of certain experiences and behaviors. So I encourage occupational therapists to really pay attention to that lens and to ask what other disciplines might be missing, because I think that we're the ones to capture those things, to identify better solutions. I just looked it up. It is the Judge Rotenberg Center is the center that continues to use electric shock therapy in Massachusetts. Yes.
In 2024, it's still happening. I think it's a good thing to know, like, because people don't know that these kinds of things even like still exist. So it's important, I think, for everybody to be aware that these things are still happening.
Right. That and I feel like if you're a parent and you have a child, an autistic child, and you take them to treatment, and if all of the medical professionals around you are like, this is the treatment we're giving, and like this and that, like I just feel like they are not equipped to decide if it's ethical or not. They're kind of just like, okay, this is the treatment provided. Like, who am I to question it? You know what I mean? And so, yeah, I feel like that could be very limiting for like parents. It's kind of like the treatment and like how their child is cared for is really dependent on just like randomly where they take them to, in theory. So
In theory and
Absolutely.
practice, I think it is. The quality of care and the messages that families receive is directly tied to where they go and what that message they hear is. And there's some recent evidence suggesting that if they hear bad messages about their kid, they're more inclined to see their child badly, which makes sense. It's completely logical. If you go to these medical practitioners who are telling you all of the difficulties of your child and how they need fixing, you're going to integrate those identities, and then suddenly you're going to be part of helping that child to, or rather fixing all of those behaviors that you've been told to fix. And now we're starting to see, hopefully, more shift to this strengths-based model, trying to help families to see the strengths of their kid. But I do think that there's still an awful lot of messaging out there that we need to cure autism, we need to stop these behaviors, and this is the way to do it. Intensive therapy constantly.
Yes, 40 hours a week.
That's
a lot.
That's job security for some people, I guess. But not great, right? And I think that's like a good topic is how do we provide education for parents and how do we kind of shift how they see autism in their child and just in general? Because as a society, I think historically and still now, we kind of there's this huge stigma that we talked about, as well as I know, like in my experience, there have been people who have had individuals in their family with autism, and they're just like, oh, can you treat them? Can I bring them to you and you treat them? And it's kind of like, well, what's going on with them? What do they need help with? So it's not really like I can't make them not have autism, nor would I want to. However, if they're struggling with certain things, then maybe, yes. So just talking about that, and I wonder how difficult or how much resistance some parents would have with it if they are kind of fixed in this, I guess, kind of mindset of like having a negative idea or association with autism, and like what does that shift look like from like shifting to like this negative idea and perception to acceptance of their child or like an individual in their family, and kind of have you seen that happen, or like what education have you provided?
There's a really unique role for us as OTs, from a clinical standpoint. I feel like when I was we have this opportunity almost across the lifespan, depending on what age group, that you end up working in. Fortunately, I loved being in early intervention. And that was kind of the time when parents are saying like, oh, my kid's not talking or my kid's not walking. There's these things going on where you can refocused, like rather than focusing on the weaknesses and what the child can't do. And, they'd be like, oh my gosh, the doctor said that there's red flags for autism. And, sometimes families and like the medical model can make that look like it's a death sentence. So we have the opportunity, I think, as clinicians and OTs of being out there. Like we're lucky enough. I had this interaction with the families. So we can talk about like, well, what does that mean to you? And what do you think that this means to your child? And like, how can we like reshift this idea, this negative viewpoint and like what they might be hearing outside, and kind of shift their perspective to looking at it from a completely different angle. And I think, OTs working in the schools have this same gift, both when working with the families, but also with the teachers. And you can use your role as an OT to be an advocate for the child, for the families, and of course, like for the education, and, the teachers and the staff and things like that. But also, we have an opportunity to also then lead and demonstrate and show by example, of how to kind of facilitate that change and how you can interact with this child and how you can improve this kind of level of engagement. And it's not this death sentence or this negative viewpoint. Like, I do think we have an important role as OTs to kind of shift that thinking from the very beginning, and then to continue that advocacy and teaching the child who eventually becomes an adult to also be able to advocate like for themselves, where they're not always just relying on others, but that they can also be like a true representative and really shift that level of thinking.
Yeah, I think it's all about continuing to support positive messaging. And I think that families need to hear the positive qualities of autism, and they need to see their child and the positive qualities that their child, their family member has. I think that any occupational therapy clinic that works primarily with autistic community members should employ autistic people as part of their clinical staff. Because when you see possibility, you can see that possibility in your child. I led a study with a colleague of mine at Towson University. And what we did is we got Towson community members who are autistic, and we recorded videos of them. We put them on YouTube, and we asked some teachers to embed them into their curriculum. And what we saw out of that data was just that these students had much more destigmatized perceptions about autism just by having these videos be incorporated into their curriculum. And it, to me, suggests that messaging really matters. And when you see people and their possibilities, suddenly you can start to integrate that into your own perceptions and beliefs about autism. But it also works against us. And so that means that anytime we go to these IEP meetings, we go to these team meetings, and we focus in on these deficits, that parent has to work extra hard to continue to see their child's strengths, because that messaging becomes incorporated into our identities and perceptions. So I think that as we are very specific in our language, as we create more opportunities for children to showcase their strengths, we'll continue to see this in turn improvement and reduction in stigma, which could really improve quality of life for the community members.
Yeah. Excuse me. I agree. And I think it's important. And it kind of sounds like working to change someone's heart to then change their mind to me. Yeah. I read one of the papers that you published, Erin, but you did a really awesome job in the paper of kind of creating a table where it writes out examples of behavioral targets in therapy practice, and then common behavioral approaches, and then neurodiversity affirming approaches. So some of the examples you have are like reducing meltdowns, aggression, or other challenging behaviors, stimming, functional play, valuing compliance and social skills and communication. And then you kind of spoke in the paper about the behavioral approaches to these, and then what on the other side of that a neurodiversity affirming approach would be. Obviously, we don't have to talk about each one. However, it would be really cool to talk about just maybe like one or two, and kind of like the historically what has the medical field done, and then what are we doing now as opposed to that.
So stimming is one of my favorite ones to talk about, because it's just there for a while. It seemed like everything occupational therapists were really interested in doing, and the field was interested in doing. And so the stimming, of course, includes a variety of repetitive behaviors, things like hand flapping, jumping, twirling of thumbs, or playing with pens. That sort of thing can all be part of an umbrella of stimming. But generally, they're repetitive behaviors that is common in the autistic community. And one of the original behaviorist approaches were pretty simple. Let's reduce stimming to get you to stop doing it. And so instead of hand flapping, you sit on your hands. Instead of flipping pens, we put the pen down, leave it on your desk, don't pick it up. We teach things like quiet hands. We've all heard many of us have heard that phrase. What are quiet hands? Well, they're hands that are in your lap, and we're sitting up, feet on the floor, quiet hands. And whole body listening is sometimes what it's called. But whole body listening isn't how most people listen. What instead you're teaching is masking or hiding your expressions of identity. Now, from this neurodiversity affirming perspective, what we would say is stim away, stim however you want, stim however you need, because that's how you're going to regulate and that's how you're going to participate in the classroom. So, and I'm thinking about the educational setting here, but if I tell a kid to not stim, they're just sitting there with their hands on their lap, thinking about keeping their hands on the lap, thinking about, I don't want to get in trouble. Or even worse, they're thinking, I'm dysregulated, and they feel uncomfortable. Remember, you might feel hangry and you might not know it. That's how the child feels in that moment. But we give them a chance. And in fact, we encourage them to stim, and we give them the space to sort of say, express yourself, however that is for you. That's how you're going to regulate your emotions. That's really wonderful. And then that client is going to achieve real participation, which is what we're aiming for. That's sort of the goal of our occupational therapy approach. So I think that broadly, this idea of let's stop the behavior so we don't see it. Now we're shifting into let's think about the purpose of that behavior. Let's think about what it's doing for this client. And let's really critically think maybe why we should or shouldn't be doing this kind of approach. And I think that that's partially been sort of the field has not. I think we're getting closer and closer to that positioning. When I say the field, I'm talking about the American Occupational Therapy Association and that very US-based lens here. But it was only just recently that they released Choosing Wisely guidance about restricted and repetitive patterns of behavior. And the guidance encourages the practitioner to reflect on what's the purpose of the behavior, and to only in very rare cases do we decrease stemming behaviors. And what I would tell most of the students I work with is primarily when that behavior is self-injurious. If it's actually hurting the client, if there's a risk that they may, that their health may decrease as a result of stemming, that's something we want to target. But if it's something that's just helping them regulate and focus, I'm not here to stop anyone from drinking their water in my classroom. I encourage all of my students to stim if they need to, because that's how they process.
Caroline, did you have anything to add?
I think Aaron did a really great job of describing that. And again, like it goes back to these invasive treatments of where we once were and kind of how we're reframing, to better understand the individual, what's meaningful for them, what feels right for them, what empowers them, and how they can be the best versions of themselves. And maybe maybe they're going to be rocking it, or maybe they have to stand at their desk to pay attention. I'm no different. So why is it not okay for you, but it's okay for me? So I just coming back to that individual and the understanding of really what's happening and why, and not inflicting our own beliefs of what we think society should expect, and making this person conform to what is deemed socially appropriate in the past.
I want to talk about emotions here, because I also think that emotions are so important for the mental health field and so important for thinking about the autism population. We said before that autistic individuals have much higher rates of depression and anxiety, and that we want to better understand what's going on. And I said that part of that is feeling like they don't belong in society, and that society's trying to change them. This is very much tied to that. Those behaviorist approaches are going to cement in one's identity that your ways of being are bad. But I also think that I want to talk about sort of behaviorist approaches to thinking about emotion. And that behavioral lens suggests that there are certain kinds of emotions that we should express them in very specific ways. You smile when you're happy, you frown when you're sad, and a range of other emotions. And that's how we should express them in very specific ways. And I think that anyone who's worked in pediatrics has likely seen somebody use some kind of emotion board where these cartoon faces of smiling and frowning yellow images. And we teach kids that these are emotions. This is what happiness is. This is what sad is. But when we talk to autistic community members and other neurodivergent populations, what we find is that emotions are much more complex than that. They're not experienced in this very specific and narrow way. That happiness is much more complex than just a smile. And I like to think about it as like happiness when you eat a really rich, creamy slice of cake, gluten-free cake for Caroline. It's fundamentally different than the happiness you might have on your wedding day or your graduation day. And even more complicated than that, the happiness you might have in an episode when somebody passes away, but they have been suffering, where there's a complicated grief mixed with some sort of relief, which may be an element of happiness for that person and their passing. Emotions are complicated and they don't fit into these narrow bands. But when we teach autistic community members, like, oh, happiness is smiling, you should smile, when that isn't how they express their emotions, what it neglects is the fact that your expression of your emotion is how you literally experience that emotion. So if you're having a great day and I tell you to stop smiling, that happiness will literally dampen for you. You'll have less happiness, less joy in that moment. And that comes down to sort of neuropsychological processing. Similarly, if you're somebody who feels happiness by smiling and I ask you to smile, you'll likely feel happier. And there's a reason why there's laughing clubs and that sort of thing where people just come together to laugh and then they feel better. It sounds fun. It is fun. But for people that are neurodivergent, whose emotions are literally fundamentally different, we're not actually reinforcing happiness. We're not helping them feel happy. What we're helping them to be able to do is to help others to think they're happy, but not to support them in actually feeling that happiness or that
and their
joy.
own happiness.
Exactly. And so I think that that's kind of where some of my work is shifting to, and sort of thinking about that question. How do we sort of resolve this gap in understanding so that way people can understand what your happiness is? And that's sort of a different lens, this neurodiversity affirming approach versus the behavioral lens.
And that's really interesting too. And you brought up a lot of good points. I feel like just in general, like humans across the whole spectrum have been kind of fed that and taught that. And so I feel like a lot of people, neurodivergent, neurotypical, whatever, struggle with emotions and processing emotions because of the way we teach emotions. And so like your example of like the complexity of like maybe feeling a little bit of happiness and relief with someone passing away, but it's also coupled with like grief and sadness and maybe even a little bit of guilt for feeling happy, right? So that is really an interesting way of putting it that I haven't thought of in depth. So, and I also
I'm gonna encourage you to think in depth about it right now, which is, so Jessica, how do you know when you're happy? What is happiness for you?
Wow. I know
That's
when I'm
a hard thing to
happy.
answer.
It is, because it is exactly different situations. I think that one thing when I'm happy, it's usually coupled with I'm relaxed. And I think that when I'm happy, there's like a sense of lightness. And I mean, sometimes I smile, but I don't always smile. I mean, I can be happy and like just not look happy. But yeah, I think like relaxed, I feel like lighter. I think those are the two.
It changes day to day. You know, like, your happiness, there's such a range. And like the way you might express your emotions related to that is a range. It might not just be one way, like where every time you feel happy, you're smiling, or every time you feel happy, like you feel relaxed. Maybe you just won a big award and you're excited and you're happy at the same time, but it's a totally different feeling.
Yeah. So there's like different things coupled with it depending on the situation. So
it's not just a smiley face emoji.
It's not. That is true.
And I would wonder, I'm not going to make you answer the question because you know, but I would wonder if you would describe yourself as feeling maybe relaxed or lighter now, and then versus happy, and like what that would mean to you and how that would resonate with your lived experience in this moment. Shifting the dialogue away from these very static emotion words that don't align with real participation. because I think what most of us can agree is that emotions they're not really static for any of us. And that's very true for the neurodivergent population, who often express their emotions using things like stemming. So instead of happiness being this sort of static smile, it might be hand flapping and jumping, which is really dynamic and expressive and exciting. And so as you jump and hand flap more, you're going to experience that happiness or joy more. Versus for you, this feeling of relaxed, maybe the more you sink into your chair and sit back away from the microphone, maybe that would be your expression of continued and broadening happiness, or whatever that positive affect thing is.
Yeah.
And neither are right or wrong.
Right. Yeah.
They both just are.
And it's so interesting because even within these couple of minutes talking about it, I think that it kind of shifted my question, because I was going to ask, do you think that it's beneficial to teach, let's say, neurodiverse populations, even though you're not trying to like change how they express their emotions? Do you think it's still beneficial to teach them, let's say, neurotypical ways of expressing emotions for them to be able to understand others? But then in having this discussion, I'm almost feeling like maybe like neurotypical individuals don't even understand themselves and their emotions. So maybe the problem is actually just changing the whole way we teach emotions in general.
I think that's probably the answer that I would say, but
Yes.
I would also say that there is utility in teaching people how other people experience the world. And that kind of goes both ways. So absolutely, it's helpful to teach autistic community members that some people smile when they're happy, and that if people don't know that you're happy, smiling might be one way to communicate that information to them. Because we all kind of do this sort of messaging thing. We're all kind of constantly in this balance about trying to show that we're engaged, or we think about how we express that information. So we all kind of do that work, much like when I was in high school and attempted to learn Spanish and was not successful. But I was learning.
No bueno.
No bueno. Yes. My favorite phrase, más despacio, por favor. Slower, please. It is part of our existence that we need to figure out how to communicate with other groups. But the other thing is, you need to have a sense of who you are and to be able to return to that. And that's where belonging comes in. Because if I'm always putting on that effort, and like I always have to do that, even at home, to express my joy, I have to point to a smiling circular face cartoon thing, then I never get an opportunity to be authentic and to be me. And that's the kind of thing that's really going to wear away and degrade your mental health. But I do fundamentally agree that we should revise the conversation around emotions and maybe think about them a little more in depth. And there's great scholars, Lisa Feldman Barrett's doing some really interesting work about emotions and thinking about how they're situated things. They're things that arise out of participation. You don't just have an emotion. You have lots dynamic things all at once.
Yeah. Wow. How have you guys, maybe specific examples of specific individuals you've worked with, been applying all of this knowledge and this shift and these new ways of providing services to individuals in the neurodiversity community?
Go ahead, Caroline.
Okay. I'm going to speak like really from like the clinical side. And in truth, I think that I was, I think when you're working as a clinician, sometimes it's hard to kind of keep up on like the most current evidence-based research and things like that out there. So I think a lot of my shift and my change, it just kind of came naturally, almost more from like a human perspective. I don't know if some of it came with maturity, some of it came with being a mom and viewing the wonderful parts of life and also like the challenging things like through a parent's eyes, as well as like viewing it, trying to view it like through my own children's eyes and seeing what they are feeling and doing. So I think a lot of it kind of came just naturally from this very humanistic like approach of like, what are we doing? Like, how is this even making sense? And like, it is one of the joys of our profession, like this opportunity for lifelong learning and reflection, and self-advocacy, and kind of always looking, as we're doing these kinds of things, or I'm watching these kinds of things like in practice, like, is this really making a difference? Is this really like what like the human experience is about? Is this really benefiting like this child? Are they enjoying this? Because ultimately when we're coming back to like occupation and us as occupational therapists, it is finding meaning and purpose, and I guess some form of happiness in things that do mean things to us. So I think my shift really came just from, and maybe it's been as like society has also been changing. And, I'm really happy with just the level of acceptance of the world these days versus like growing up and where we used to be, and looking at my own children and like just how like they're just really great humans, and can kind of, they are just so much more embracing of change and differences. And they, I don't know. I think that that's been part of it. And now coming into academia, it's been really great because now I have access to all of these kinds of things where I, kind of lost touch with the most current evidence and things. And actually seeing like, yes, this really is a thing. Like, this is really happening. And we are moving in this very positive direction, like as a society. And, we do have autistic individuals, like where we actually hear their voice and like what they've been going through. So I think it's really like been a natural shift of just kind of watching like the old ways and realizing like, this is not who we are as a profession. And this is not where, it's not very humanistic, and this is not where I see things going. Like, how are we really going to use this strength base? How are we really going to look at the individual that we're serving? No matter the diagnosis doesn't matter. We are serving the individual or the family, or the community, the population, whatever. But ultimately, that's what it comes back to. So I don't even know how I really got on like that topic, but I think it was just like a natural way of kind of looking at things through like a different lens.
Yeah.
And always trying to just come back to to our foundations and the fundamentals of like, why are we here and what are we doing?
Yeah.
Yeah, I can do a little bit of shameless self-promotion here to talk a little bit about one of the interventions that I'm doing now. But I remember one of my more recent jobs clinically was working in a high school for folks with developmental disabilities. And at that point, I was early in my neurodiversity affirming space and still learning a lot. And so one of my interventions were very individualistic. And I focused a lot on, I was interested in transition skills, certainly, but we did a lot of focus on working with individuals to build resumes, work on job skills, work in isolation was the focus. And it was still very therapist driven. And as I reflected on my practice and the ways that I wanted to shift it into this neurodiversity affirming model, the practice started to change a little bit. And that's where sort of I'm at now. And so what I've developed is a group that we call ourselves Nexus, but it's a transition skills social club thing that happens in Newark, New Jersey. And what it is it's a group of young adults getting together, and we're learning transition skills together as a group. And when if you would have come into my sessions when I was a new OT grad, you would have seen me with lovely session plans and really great every minute planned out and extra activities in case things go wrong. Well, now what I do is I give the members and the Nexus members and the groups that I work with, my clients, more opportunity to express agency in what and how we do. So, for example, more recently in one of our interventions, one of our group members was writing a resume, and she wanted to teach our other group members how they could write a resume. This autistic young lady flourished in this role. And sure, she was still figuring out exactly how to communicate and how to lead. But what a better space to do that than in this social group where she can do that. And she can make mistakes, which is the other core feature of Nexus. Everyone who participates in Nexus, we talk about this. There's a lot of beauty in making mistakes. And I was trained in errorless learning. Let's get our students to, support them all around so they can do everything perfect. But there's such wonderful things to do in an error. When I make a mistake, I can learn from it. And that's what we do at Nexus. We make mistakes. We make food. When we're deciding on recipes to make and new skills we want to learn, our members plan it. And sometimes things go wrong, and then we problem solve and figure it out as we go. So I decentralize myself in my therapy and give them, the members, these autistic young adults that are just such a wonderful, I've learned so much from them, give them an opportunity to mentor us, to decide what we do and how we do it. And so we're all accountable as part of the approach. Sure, there's some skilled intervention that happens, that training of that unique training of an occupational therapist. We can create that context, but it's very much about decentralizing the role of the clinician.
Yeah. I love that. That was a great example. And I think, some themes that I'm noticing between both of you guys is one of which as a clinician, having the capacity to self-reflect and be self-aware in your practice and how important that is. And then also the ability to be able to kind of step back, and in order to give like the client more agency and more control, you have to be a little less controlling of the whole environment itself and kind of let them take control, or what's going to happen. And I think that is when a lot of effective interventions happen. But that's what I'm hearing, at least my takeaways from some of y'all's examples.
Yeah, I think that is it. Self-reflect. It's okay to learn and grow. Give your client a chance to have some agency and for processes to happen and unfold, because that's really what mimics occupational participation in itself. That's what occupation is. It's an opportunity for us all to push and press and move throughout our environments and our spaces. And then I think it's a little bit of just appreciating the other and appreciating that people are going to experience the world differently from us. And that's what makes the world a much more rich and engaging space. Let's take the moment to learn through them and to see the world in them. And then our world is going to become much more colorful, much more rich, much more diverse. And that's where this work really lends us into a richer world, a more diverse world, and a more colorful and engaging world to be a part of.
Gives me so much hope.
Wow. All three of us are so great. No. But yeah, and also with that too, a big takeaway as well is just having the courage as a clinician to ask why. Like, why are we doing this? Is like a huge reoccurring theme, I think, throughout what we've been talking about, which also ties in with self-reflection. But sometimes it can be hard to ask why if everyone else is doing it this way, and it kind of seems like that's like the way to do it. So, yeah. Caroline, do you have any specific interventions that you want to talk about that reflect kind of this theme?
I think that there's any like specific intervention. I think the biggest piece is kind of like building off of like what Aaron had said, like really coming back to like the individual and letting them guide. You know, as OTs, we can write beautiful treatment plans. Like, you know, I could write treatment plans and intervention ideas like in my sleep. That doesn't mean that they're meaningful for who I'm working with. So always coming back and being super client-centered and putting them first and foremost, letting them guide and taking that like back seat, because then things are going to be more interesting. So maybe they are really interested in trucks and trains, and that's like their area of interest. How can we use that to then apply, like if they are in a school setting, you know, how can we use what interests them to then help them to access like their educational curriculum and be a little bit, you know, to be successful, to feel like they belong, to be part of this educational community. So I don't think there's one be all end all intervention, except for really putting the client first, viewing it like they are a human, understanding that human relationship, the human perspective, learning through them. I think that ultimately that's what it all really comes back to. And like Aaron had said, like this gives us an opportunity to build like love and relationships and grow, and the world to be a more generous and kind and embracing like community versus like where we were in the past. We can always look back in the past. We've all like, we look at the past, I mean, across history, and there's so many like faults, but they have provided us opportunities to learn. So being that reflective therapist and always finding like, it's okay like to make the mistake, just like it's okay to make a mistake in front of the client that you're working with. Like, well, I just made a mistake too. Do you see? Like I can learn from this experience too, and allowing them to make mistakes and problem solve through it, and really being a partner to the client rather than like the therapist and the client. Like
Right.
you're equals, you're working together and developing that plan together. So I know that doesn't solve with like one big primary intervention, but always putting the person first.
Yeah. And I think that was a very well put way, and kind of what I was trying to get at earlier when I was kind of talking about the disconnect between education and maybe like the person and treating the person, is because, as you said, like you could provide all of these great resources and all of these great treatment plans and this and that, and everything might look great on paper, and like you're doing everything like the way you're supposed to, based on like the education you've had, but like none of it matters if it doesn't matter to the client.
Exactly.
So it's like optics versus like real life almost.
That's exactly it. And and that's who we are at the core, right? As occupational therapists, like we are so humanistic and person-centered, like coming back to our foundation, our basic, and why we ended up in this field, because it takes a certain kind of person to really become like an occupational therapist and embrace what OT really is. And it's not, OT is not me just giving you an intervention or deciding that we are doing brushing or this is your sensory diet because this is what I prescribed. That's not OT. OT is about like the person.
Yeah. And I also think too, especially with like pediatric populations, I mean, kids are told like growing up, like everyone's always in charge of them. And I can imagine that it would be probably easy in these settings, and they're used to it. Like, this is what we're doing today. This is, you know, the plan. But maybe for some of the kids that you work with, it's the first time in their life that they actually are given some agency and they actually are listened to and validated. So, I mean, even just with that, like that's an incredible experience for them, I'm sure, and provides mental health care, right? Improves their mental health, improves their probably self-confidence, everything.
I think it really ties back to the story that when you were talking about like what is strength-based approach too, like when you give the opportunity for your client, I always say kiddos because most of my clinical practice, like my full-time work has all been with peds. So I always default in that direction, but like to give them the opportunity to shine, I think it gives them the opportunity for them to also identify the strengths within themselves. Like, oh my gosh, like I created this obstacle course. Like, look what I did. Like, and I helped the other, like, you know, students in my group be able to do this, or they were having difficulty, I don't know, with cutting. And then I was able to come up with the plan and was able to help them. Like, I think giving them those opportunities to shine, not only, I mean, of course it's going to help like with your mental health, but I mean, that deep seated root of like owning like your strengths and recognizing them like in the moment where they can recognize it for themselves, even with outside of me going like, wow, that was incredible. Great job. You know, like they own that. And I think like it's a huge piece of like the mental health and the sense of belonging and being part of like this community, whether you're an outpatient or school-based or in, you know, the community, giving them those opportunities to shine.
Yeah. And it gives them real life examples to recreate the narrative about themselves. Because I think all day long we can like tell them how great they are, or like other people can tell them how great they are, but until they're put in a position to utilize their strengths and their skills, it just seems inflated, or it seems like empty or hollow. But when they are able to do those things and then see those things and reflect, wow, I can do this. And, you know, the narrative people have been telling me about my life, I don't necessarily have to completely identify with that anymore, because I'm now reconstructing my own narrative about what I can do and who I am and what my strengths are.
Exactly it. That sense of like self-worth. That no matter how much praise you get from others, it has to come from within.
Yeah.
Sorry, Aaron.
I think that's a fantastic phrase to describe this approach, recreating the narrative and giving clients the opportunities to write their own stories. We know that in the mental health community broadly, thinking about this whole population, there's this learned helplessness because all throughout their lives, they're told that their experiences aren't valid and that they should listen to you. I worked with this one gentleman who came to Nexus, and I remember his first few weeks there. Every step of the way, he would ask us, can I do this? What should I do next? What should I do next? What's next? And then just the other day he came in, I asked him how he was. We were getting ready to get the group going and to do some things. And I was like, oh, do you want some coffee? And he was like, yep. And he went up to the coffee maker, made himself coffee, asked me if I wanted coffee or tea, and made everything for all of us, all by himself, completely independent. And for him, I can tell you his narrative has shifted about what he can do, who he is, and he started to incorporate that into his experiences when he comes into the space. He knows he has ownership there, and that's who he is now. And I think that the more that we give our clients the opportunity to create these narratives about themselves, it's going to cross into other settings, and it's going to work against that learned helplessness and very much support these feelings of belonging. And I think it's really going to, I already have heard from some of the participants at Nexus and their parents about how they're increasingly doing more and more at home. They're going out in the community because they're starting to change the way they see themselves.
Yeah. Did we just solve
my
all
heart
the
so
world's
happy.
problems?
I think so.
I think we did.
So.
Wow. No,
really
all
think
of
we
this has
did.
been so great. Those are all the questions I have for you guys, but I want to open up the floor to any closing remarks, or maybe even some topics maybe we didn't get to that are like really burning desires for you to talk about. So yeah, the floor is open. Anything you have to say.
I could just talk forever, but
I can put a timer on.
Please, yes. I require 4 hours minimum.
Wow.
For my soliloquy.
Might have to do segments for this one.
Part 1 through 5. I think there's a couple of messages that are really important here. And the first is that what we're talking about, it feels big, and it's so big and important for our clients. But I'm not asking anybody to go out and throw out every one of their session plans. It's little tweaks. Little tweaks are what you can do to affirm your clients and give them the opportunity to, as you said, Jessica, recreate their narratives. And I also think that this work fundamentally puts a lot of the onus of this intervention development on the clients, and it gives them an opportunity to be part of the process. So this idea that you need to overplan, you need to come in with a billion plans. Yes, we need to have lots of tools in our toolboxes, but I would just encourage clinicians to think about the ways that they can put some of that responsibility on this community and give them a chance to come up with the outcomes that are meaningful for them. And I think clinicians will find that it really enriches their practice and helps them to think even more creatively, and brings back some of that beauty that might have brought them into the profession in the first place. The other thing that I want to encourage clinicians to reflect on is that I at no point would say that this is the end, that we've done it, we've reached the end of the best thing we could ever accomplish, right? This is just moving the goalpost a little bit further, getting us a little bit more into this ethical practice range and doing the things that our clients want us to do that are meaningful to them. But I can't wait for hopefully next year, but a decade probably, when we come up with a new idea about how to do this work even better. It's going to improve our practice even more. So continue to sort of be interested in this innovative practice areas, and it'll really improve your practice. And I've reminded myself the third thing in my 5-hour soliloquy I was going to say, which is this reminder that the principles of neurodiversity extend beyond our clients. Sometimes I think it's really easy to think of, when I'm a clinician, I'm a neurodiversity affirming practitioner. But I want to encourage all of us to spend the time to do some of that self-reflection, as you said, to think about how neurodiversity might change how we approach our friends, how we approach our teachers, how we approach sort of everyone in our sphere of space. Because I know I can easily enter into a very easy judgment space, like, oh, that person's weird, or I don't like how they make me feel uncomfortable. They're so direct. They're so this thing. The person might, they could be mean, and that's true. And those people are out there for sure. But let's put on that self-reflective lens and think about how we can be neurodiversity affirming friends. How can we be neurodiversity affirming educators, neurodiversity affirming advisors, neurodiversity affirming, insert any one of your roles that you might operate in a specific context, because that's what we're trying to create, I think, in this lens. It's not just about what do we do as therapists. It's about creating a better world and a more inclusive world where community members feel like they belong. And that means that we have to adopt this perspective, not just in the clinical context, but in all of the contexts that we operate from, and to encourage our friends to do the same. It's okay to invite your friends into this conversation, to get them thinking about what this might mean, and then to challenge them if they're not being neurodiversity affirming. Give them a chance to do some of that work of self-reflection so that we can do this work a little bit better and move the goalpost a little bit further.
Yeah, definitely. And I think there's a way to elicit those conversations and provide education without being condescending.
Yes.
And so that's also a very important thing, because if you come off as arrogant or condescending or any that, it shuts it down, and you have lost that person completely. But yeah, just finding a way to find common ground and provide that education in a safe space, for sure.
So how do you do that, Jessica?
Well, that's a great question. I think for me, when I am just around people and they have certain questions, I think that relate to this topic, I think that those are perfect times, because if they're asking me a question, then they are obviously showing curiosity, and they're showing openness and willingness to receive what I have to give. And so really finding those opportunistic moments to provide it, but also in a way where you are kind of providing maybe the education you've received in a non-threatening and easily understandable way, and maybe relating it to them, and not pointing out what they're doing wrong, but maybe this is another way you could look at it, providing different perspective, and asking them questions too, well, what do you think about this, or how do you feel whenever this is happening, or you're engaging in this way, and what's your perspective on this, and just providing a different outlook on it, I think. So
yeah, I agree. I think go ahead, Caroline.
Oh, I was gonna say I completely agree. And I think the opportunity to share our vision and kind of advocate and educate, both in the clinic and outside the clinic, is what's going to really make the world a kinder, more accepting, empowering environment for all, regardless of your gender, your religion, your disability status, everybody's kind of viewed more equally, and understanding the unique differences, which comes back to all of those factors of like religion and ethnicity and things like that. Neurodiversity is just one more, and the disability community is just one more that makes us very, like, each individual very unique. So I love, like, I just am very thankful that, you know, you invited us here today to have this opportunity to kind of talk about these things that we are really passionate about. And I hope that maybe it just lights a little fire and, you know, triggers some self-reflection and promotion so that, like, we can continue to kind of get this word and these positive vibes like out there on how we should, lots of positive vibes out there on how we should be looking, you know, and taking it always back to the human.
Yeah, I agree. All right. Well, I'm glad that y'all agreed with what I said. I appreciate you challenging me throughout this podcast, Erin, and asking me questions, putting me on the spot a little bit, but it's good for me. I'm usually when I'm asked questions like that, I like to have ample time to like really reflect and like give like a very good, thorough answer. But I think it's also good for me to like in the moment provide like a good answer. So you're providing interventions for me right now.
Well, I think it's nice for us all to sort of explore these concepts and to sort of open up lots of conversations. I think that we don't have to have perfect answers. And sometimes I think coming up with scripted perfect answers doesn't mimic real life experience. And so it's okay to model and for your thinking to evolve even as you go, I think. Which is where I think sort of my approach to sort of modeling neurodiversity and like thinking about it as friends kind of comes into is just trying to infuse into society this idea that like, oh, I made a mistake. I was judging that person, and that's my own habits and routines coming in. And just doing that, just the simple act of being reflective encourages other people to do the same kind of work or just infuses those ideas into them. So that's something that I try and do as much as I can, that to own my own biases, own my own preconceptions, and also own that like if you're loud, I'm probably not going to like you because it's just who I am.
It's too loud.
Yeah, and that's okay. That's okay. That's part of who I am, and I'm okay with that.
Yeah. I've definitely, from some of the clients, we had like a discussion of like, well, what like are your triggers and like what are your kind of like boundaries and stuff like that. And like there was one specific person, they're like, Jessica, like you just come in with too much energy and like you're too like up and like alive, and they're like, it's too early for this and like all that, and which some people love it and some people like they feed off it, but some people it's just like, no, please stop. So it's like, and like fair enough, I will keep that in mind when I interact with you at 9 a.m. Maybe it won't come on too strong. So yeah,
that reminds me of my favorite teaching evaluation feedback I've ever received was that I was annoyingly enthusiastic. And I think I've incorporated that into my identity. I am annoyingly enthusiastic as an instructor.
There are worse things to be, I will say.
Yeah.
And I think also it's really good practice to like be able to receive feedback and weed out like, you know, maybe I am, but also like that's okay with me. And so maybe I don't have to change this, or like vice versa with like, oh, like maybe I haven't like really reflected, like this is how I am. And maybe I want to work on changing this. So
that would be a great podcast. How to receive feedback and like navigating difficult conversations and identity as an OT. Because I think, I mean, mental health and OTs for us as a population is something that we should also be thinking about.
It's a good idea for next time.
When you have us back.
Yes, exactly.
She's not inviting us back. We talk too much. It's okay.
I'll block out 5 hours next time. I'm sorry to cut it off short. But okay, yeah, I think, like I said, that's all I have. Thank you guys. I know just from the time I've spent speaking with you, I feel like I have changed a little bit. And it's not about, you know, perfection. It's about progress. But yeah, I think I can confidently say that I have made progress just in this discussion, and I think that it'll reflect in my practice and hopefully in the outcomes of my clients. So thank you.
Thank you so
for
much,
the
Jessica.
opportunity.
Yeah, absolutely.